Welcome to the Deep Dive, where we take your source material and distill the essential knowledge you need fast. Today, we are deep diving into the world of cholinergic drugs, the ultimate pharmacological chill pills, also known as cholinergic agonists or parasympathomimetics.
That last name, parasympathomimetics, it really says it all, doesn't it?
Yeah.
We are basically chemically mimicking the entire system responsible for rest and digest. That's the parasympathetic nervous system, or PNS.
Right. So our mission today is to unpack how forcing the body into this, well, highly relaxed state actually works, and maybe more importantly, how clinicians manage its pretty profound effects.
Exactly. And before we even get to the drugs themselves, we need to lay the groundwork. It all comes down to one key neurotransmitter.
Acetylcholine, or ASHE, that's the one. So what happens when ASHE actually transmits that signal?
Well, Ishi is the messenger, right? And its message gets picked up by one of two main receptor types. And where those receptors are located really dictates the downstream effects.
Okay, so you've got the nicotinic receptors versus the muscarinic receptors. What's the difference in terms of patient impact if we stimulate one versus the other?
Well, the nicotinic receptors, they're found in the ganglia of both the PNS and, interestingly, the sympathetic nervous system, too. They get stimulated by nicotine, obviously.
Hence the name.
Precisely. And hitting those is often responsible for some of the side effects, especially if the drug dose gets too high. But the real targets, the ones we're aiming for with these therapies, are the muscarinic receptors.
Ah, the muscarinic one's named after muscarine, that mushroom alkaloid.
You got it. These are really the rest and digest switches. They sit postsynaptically in the effector organs. Think smooth muscle, the heart, various glands. Stimulate these, and you instantly see things like a slower heart rate, more GI secretions, constricted pupils.
And the bladder getting the signal to empty.
Exactly. It's the core PNS response.
Okay, let's unpack this a bit more then. So the drugs mimic HE, but they go about it in two pretty different ways. How do we categorize those two major classes?
Yeah, we split them based on how they work, their mechanism of action. First, you've got the direct-acting agonists. These are pretty straightforward. They physically latch onto the cholinergic receptors and just switch them on.
Like flipping a switch directly. You mentioned bethanechol as an example.
Right. Bethanechol is a classic direct-acting one. Then the second class, the indirect-acting agonists, often called cholinesterase inhibitors. They're a bit more, well, indirect.
Indirect. Sounds like they're blocking something instead of activating.
They are. They block the cleanup crew. So normally, there's an enzyme called acetylcholinesterase, ACE, that quickly breaks down acetylcholine after it does its job.
So it doesn't just linger there forever.
Exactly. These indirect drugs inhibit ACE. By stopping that cleanup enzyme, they let the body's own natural AC build up and hang around longer at the synapse. This effectively increases the stimulation duration.
That's where drugs like donepezil and pyridostigmine come in.
Correct. Donepezil for Alzheimer's, pyridostigmine often for myasthenia gravis. And you also mentioned this difference between reversible and irreversible inhibitors. That sounds pretty serious.
It is. If someone's exposed to an irreversible inhibitor, like, say, certain nerve agents or pesticides, the enzyme is basically knocked out permanently.
That's the critical point. The binding is so strong, the body literally has to synthesize brand new cholinesterase and enzymes to get back to normal function. It's not just waiting for the drug to wear off.
Wow, that really underscores the potential danger and why these compounds need such careful handling. So, okay, whether it's direct or indirect, the stimulation happens. What does that stimulation do systemically? Let's run through that rest and digest checklist again.
Right, so the cell membrane depolarizes, calcium and sodium rush in, and the effector organ gets the signal. In the GI and GU tracts, you see increased secretions, increased motility.
Things get moving.
Definitely. And the sphincters relax, which helps things empty out. In the eyes, you get miosis, that's pupil constriction. This actually helps lower intraocular pressure, which can be useful.
Okay, what about the heart and lungs?
Cardiovascularly, heart rate drops. And you get vasodilation, so blood pressure might decrease. Pulmonarily, the bronchioles constrict, narrowing the airways, and secretions increase.
And this is where dose becomes really crucial, right? At the recommended doses, you get those desired muscarinic effects, but push it too high.
Then you start stimulating those nicotinic receptors more prominently. And that's often where unwanted side effects pop up. Things like muscle twitching, maybe even a rapid heart rate, which is counterintuitive, general unpleasant overstimulation that kind of overrides the therapeutic goal.
Got it. Let's zone in on some specific drugs and why we use them, starting with something fundamental, just getting things moving through the body when they're sluggish.
Right. For situations like postoperative GI or bladder atony, basically when the muscle tone is weak or absent, we often turn to bethanechol. Since it's direct acting, it gives a pretty quick, targeted push.
So it increases the tone and motility in the bladder and GI tract, helps things empty, like if someone has not obstructive urinary retention.
Exactly. It just gives those muscles a nudge to overcome that sluggishness. Now let's switch gears to strengthening muscles, particularly in conditions like myasthenia gravis or MG.
Ah, MG, that's a classic use case. Which drugs are key here?
For MG, we mainly use the indirect-acting drugs, the ACE inhibitors. By boosting the available ACE at the neuromuscular junction, they improve skeletal muscle contraction and strength.
Okay, so which specific ones?
Pyridostigmine is really the workhorse drug for managing the day-to-day symptoms, helping patients regain muscle strength. Then there's edrophonium, which has a much shorter action.
Isn't that the one used for diagnosis?
Precisely. It's used in the Tensilon test. You give it, and if the patient's weakness rapidly improves, it points towards MG. It can also help differentiate an MG flare-up from the opposite problem, a cholinergic crisis, where there's too much stimulation.
And one more, physostigmine. You mentioned it's like a pharmacological fire extinguisher.
Yeah, that's a good way to put it. It's the primary antidote for severe anticholinergic poisoning. Think overdoses of things like tricyclic antidepressants or even certain plants. It crosses the blood-brain barrier and reverses those blocking effects.
Okay, we've covered muscles, sphincters, glands, but now the perhaps surprising target, the brain. How does this rest and digest system connect to something like Alzheimer's disease?
It's a really interesting link. Alzheimer's involves a pretty significant drop in AT levels, specifically in brain areas crucial for memory and cognition.
So the idea is to boost the ACX that's still there.
Exactly. We use indirect-acting HE inhibitors like donepezil, galantamine, and rivastigmine. By increasing HE concentrations in the brain, the hope is to enhance or at least stabilize memory and learning capabilities. Rivastigmine is also used sometimes for dementia associated with Parkinson's.
But, and this seems like a big but, the source material mentioned that the therapeutic efficacy is highly variable. Only about 15% to 30% of patients actually see a benefit.
Yeah, that's the tough reality. It means these drugs are purely symptomatic treatments. They don't cure the disease or stop its progression. The goal is more about potentially slowing the decline, maintaining function for a bit longer, improving quality of life, even if it's temporary.
So managing expectations for patients and families is absolutely critical here. They need to understand it's not a guaranteed fix.
Absolutely crucial. And it also means that if a patient doesn't respond after a decent trial period, continuing the drug might not make sense, given the potential side effects.
We should probably quickly clarify memantine, too, since it often gets mentioned in the Alzheimer's context.
Good point. Memantine is used for Alzheimer's, often together with these cholinergic drugs, but it works completely differently. It's an NMDA receptor antagonist, not a cholinergic drug. It targets a different pathway involved in the disease process.
Okay. Now, because we're essentially putting the PNS into overdrive with these drugs, safety is a huge concern. Let's talk contraindications, the absolute red flags.
And number one, of course, is a known drug allergy. But clinically, a massive one is any kind of pre-existing GI or GU tract obstruction.
Why is that so critical?
Well, think about it. If you give a drug like bethanechol, designed to increase motility and pressure, but there's a blockage, you risk perforation, tearing the bowel or bladder. It's a surgical emergency.
Okay, that's a serious risk. It really drives home the need for a thorough assessment first, making sure the coast is clear, so to speak.
Absolutely. Always check for signs like abdominal distension, hypoactive or absent bowel sounds, inability to pass gas. Non-pharmacologic measures like getting the patient walking, ensuring hydration, those should always be considered first if there's any doubt.
What other contraindications are on the list?
Things like significant bradycardia, low blood pressure, certain heart conduction defects, epilepsy, hyperthyroidism for some reason, and definitely severe COPD because of that risk of bronchoconstriction making breathing much harder.
Makes sense. So even if there's no absolute contraindication, patients will likely experience some side effects from this PNS overstimulation. What are the common ones they might report?
They follow directly from the mechanism, really. Cardiovascularly, you might see that slow heart rate, maybe hypotension leading to dizziness or even fainting syncope.
Okay. GI system?
Very common.
Yeah.
Abdominal cramps, increased saliva and stomach acid, nausea, vomiting, diarrhea, basically everything's overactive.
And respiratory.
Increased bronchial secretions, which can be problematic, and that bronchospasm or airway narrowing we mentioned.
Right, now for the worst case scenario. What happens if someone gets too much? An overdose, accidental exposure, the cholinergic crisis. What are the signs a clinician absolutely must recognize?
It can escalate really fast.
Yeah.
Early signs might be abdominal cramps, excessive salivation, skin flushing, nausea, vomiting. But it can quickly progress to severe circulatory collapse, shock, bloody diarrhea, and even cardiac arrest.
There's that mnemonic clinicians use, right, to remember the key signs.
Yes, it's incredibly useful, especially under pressure. SLUDGE it stands for. Salivation, lacrimation, tearing, urinary incontinence, diarrhea, GI cramps, and emesis, vomiting. If you see that constellation, think cholinergic crisis.
SLUDGE. Okay, that sticks. So you suspect a crisis. What's the immediate life-saving treatment?
Time is critical. The primary antidote is atropine. It's a cholinergic antagonist, so it directly blocks the muscarinic receptors being overstimulated. It needs to be given promptly.
And is there anything else?
In severe cases, especially with major cardiovascular collapse or severe bronchoconstriction, epinephrine might also be needed. It's an adrenergic agonist working on the sympathetic side to counteract those life-threatening effects.
And just quickly on interactions, basically, anything that dries things up or speeds the heart up is going to fight against these drugs, right?
Exactly. Anticholinergics like atropine itself, many antihistamines which have anticholinergic properties, and sympathomimetics, drugs that mimic the sympathetic nervous system, they will all antagonize or reduce the effects of cholinergic drugs.
Okay, let's connect this back to the bedside and the nursing process. When a clinician is actually administering these potent drugs, what are the critical nursing considerations?
It starts with that thorough assessment. We talked about ruling out obstruction, but baseline vital signs are non-negotiable, especially blood pressure.
Why BP specifically?
Because of that risk for orthostatic hypotension, gaddiness, or fainting when changing position, you need that baseline to know if the drug is causing a significant drop. If someone's already hypotensive or bradycardic, giving a cholinergic agonist could be dangerous.
And for Alzheimer's patients getting drugs like donepezil, what's key in the assessment phase there?
You need a good baseline neurological assessment, obviously focusing on memory, cognition, and their ability to perform daily activities. But also, critically, assess the family support system. Caregivers are essential for managing these meds and monitoring effects, especially since improvement can take up to 6 weeks, if it happens at all.
Let's talk implementation. For myasthenia gravis patients, you mentioned timing the dose before meals. Why is that femominute window so important?
It's all about function and safety. Giving pyridostigmine about 30 minutes before eating allows the medication to peak, strengthening the chewing and swallowing muscles just when the patient needs them most. This significantly reduces the risk of choking or aspiration, what we call dysphagia.
That makes a huge difference in their ability to eat safely and get adequate nutrition. What about general safety education for all patients on these drugs?
The big one is fall risk due to potential dizziness or syncope from that postural hypotension. So standard patient education includes telling them to change positions, slowly sit up for a bit before standing, dangle their legs.
And for the Alzheimer's drugs, what specific education points are vital?
Reinforcing that the drug treats symptoms but isn't a cure is paramount. Also, stressing that they should never abruptly stop the medication. Abrupt withdrawal can cause the rapid worsening of cognitive function. If it needs to be stopped, it has to be tapered off gradually under guidance.
Any specific administration tips, like those dissolving tablets?
Oh yeah, for orally disintegrating tablets, like some forms of donepezil, the instruction is clear. Place it on the tongue, let it dissolve completely, then swallow, with or without water. Don't chew or crush it.
Good practical tip. Now, you mentioned evidence-based practice earlier, something about walking and Alzheimer's.
Yes, it was a really interesting finding. A study showed that while sedentary AD patients generally decline cognitively over a year, those who engaged in walking for just an hour or more per week actually showed stabilization in their cognitive function.
Wow, just an hour a week. That's a simple, accessible, non-pharmacologic intervention nurses can absolutely encourage. It really speaks to a holistic approach.
It really does. It shows how lifestyle factors can interact with pharmacology. Right. It emphasizes treating the whole person, not just the neurotransmitter levels. So finally, evaluation.
Yeah.
How do we know if the drug is actually working? What are we monitoring for?
We look for specific improvements related to the indication. For urinary retention treated with bethanechol, we want to see the patient voiding, ideally within about 60 minutes. For MG, we look for objective signs of improved muscle strength, less eyelid drooping, mitosis, less double vision, diplopia, improved swallowing.
And for the GI uses?
Increased bowel sounds, maybe passing flatus, reports of less bloating or abdominal discomfort. Basically signs that things are moving again.
Okay, let's do a quick recap. We dove into the rest and digest system, focusing on the neurotransmitter acetylcholine, ACO, and its two main receptor types, muscarinic and nicotinic.
We differentiated the direct-acting agonists like bethanechol from the indirect-acting cholinesterase inhibitors like pyridostigmine for MG and donepezil used for Alzheimer's despite those challenging odds of efficacy. We covered the serious risks, especially cholinergic crisis, remembering the SLUDGE mnemonic and the critical importance of the antidote, atropine. And we tied it all together with key nursing process points: assessment for obstruction, implementation timing for MG, and crucial patient education.
Which leads to maybe a final thought for you to consider. This whole class of drugs is incredibly powerful, precisely because it forces a major shift in our body's autonomic balance.
Right.
Right? It mimics the parasympathetic system.
Right.
So if chemically forcing that rest and digest state is potent enough to potentially cause a crisis, requiring an emergency antidote like atropine, what does that tell us about the inherent power and importance of our body's natural ability to enter that state? Why is maintaining that parasympathetic sympathetic equilibrium so absolutely fundamental to our overall health and well-being?
That's a really compelling point to reflect on the power of our own internal balance. Thank you for joining us for this deep dive into the source material. We hope you feel thoroughly informed and ready to apply this knowledge.